Hey guys, welcome back to another episode of Nurse Diaries Women's Health Project. So I'm with another guest speaker, so can you please introduce yourself and let us know what you do?
Hi guys, my name is Frances. I'm a gynae and early pregnancy nurse.
Okay Frances, so can you just explain to us your chosen topic?
So I've decided to speak about ectopic pregnancies today.
Okay, so can you just explain to us what you know about ectopic pregnancies and why you've chosen this topic?
So I've chosen this topic because I feel like it's a topic that we don't really speak about as women, we don't really speak about in general, to be honest. So an ectopic pregnancy, in the most simple terms, is basically when a pregnancy is not growing in the right place, i.e. the uterus. It could be growing in the fallopian tube, either left or right. The most common symptoms that I've seen so far would be the shoulder tip pain, diarrhea, and the localized pain. And also another symptom would be bleeding. It doesn't have to be, it's not heavy bleeding, but any type of bleeding. So in the clinic that I work in, we do early pregnancy scans, and one of the diagnoses that could be made during these scans are an ectopic pregnancies. So it could be a confirmed ectopic pregnancies where in the scan you can see the pregnancy growing outside the uterus clearly. That would be a confirmed ectopic. Or it could be that your scan turns out to be what we call PUL, which is a pregnancy of unknown location. These could be one of two things. It could either be query ectopic, or it could be that you are just early, that your pregnancy is not developed to the point where we can see it on a scan yet. So once you've been diagnosed with a PUL on a scan, we have one pathway, which is that we take a beta-HCG hormone, which is a pregnancy hormone level blood test, and then we repeat one in 48 hours. And then as a nurse working in the early pregnancy unit, it varies from whatever clinic you work in. We as nurses, we take a look at the trend from the first HCG level to the second HCG level. We usually expect a rise of 63%. Say that this is an ongoing pregnancy. If the trend, if the second hormone level that we've taken is below the first one, so there's a decrease, then we would say it's a failing pregnancy. However, if the HCG level, the second one, is within the same range or it hasn't increased up to 63%, then we would say it is most likely an ectopic. We call it a static HCG. We can either repeat the HCG again, so that means you'd have a third HCG, and if in some cases it rises by 63% and it's above 1,500, then we would opt for another scan. If it doesn't rise above 63% and it's still the same type of range as the other ones, then we would say this is most likely an ectopic pregnancy because of how static the HCGs are. And like I said before, if it decreases, it's a failing pregnancy. So once we basically have the blood tests to say that these HCGs are static, we book them in for a scan to just see whether we can actually now see the ectopic pregnancy. Some cases we can, some cases we can't. And depending on how hemodynamically stable the patient is, it tells us how fast they really need surgery. In most cases they need surgery because you can't always see an ectopic pregnancy on a scan. So the surgery that they have is a diagnostic laparoscopy, where either the left or the right fallopian tube, depending on how big the pregnancy is or where the pregnancy is usually cut open and the pregnancy is removed, or in some cases the whole tube has to be taken out. In these cases, if a lady has had, we call it a right salpingectomy or a left salpingectomy, the next time they get pregnant, they are eligible for an early pregnancy scan at 6 to 7 weeks. 1 in 90 women have ectopic pregnancies. It's not as rare as you think. It is actually more common than you think. So The ladies that I would say are more at risk of having ectopic pregnancy would be ladies who have had a previous ectopic pregnancy, ladies who have had a C-section. If a doctor is querying a C-section ectopic, it's quite serious because it's more likely to rupture. It can be quite fatal if diagnosed. This is because that the likelihood of it rupturing is more compared to a normal standard ectopic, but both of them, the risk of rupture is both imminent, if that makes sense. So that's why when diagnosing ectopic pregnancy, you need to act fast. You need to make sure that the patient understands the risks, especially if the patient is actually stable. They can rupture at any moment and they can become very hemodynamically unstable. So they just need a lot of safety netting if the doctor thinks it's okay for them to go home and come back for another blood test, say if they need another one. Safety netting as a nurse is very key, and also documenting that you have safety netted this person, because I have seen cases where a patient is stable, we are querying an ectopic, and then she goes home and they rupture. And I think that they have not been safety netted enough to know the symptoms and know the warning signs, to know to call an ambulance, to call 111, or to call us, because in our clinic we say if you have any increased abdo pain, both centralized or not centralized general abdo pain, if you have any increased PV bleeding, you need to give us a call so we can bring you in. Some patients aren't safety netted with this advice and they go home and they think, oh, just a bit of bleeding. The next moment, you know, they are very, very unwell and they are in a lot of pain. And basically when an ectopic pregnancy ruptures, their belly fills with blood, and that's what makes it so risky and so dangerous.
I just want to end this off with asking just 2 questions. So the first one is, what do you enjoy being a gynaecology and early pregnancy nurse?
I love the fact that you're able to help women in their most vulnerable state. I think that I feel like as a woman, we all go through things, and I feel like especially when someone is in such a vulnerable state, knowing that they have the support there makes things 10 times better, and knowing that they know that you're there to support them, and they know that they can ask any questions and know that they're actually not alone going through whatever they're going through, gynae, early pregnancy related, anything related really. And I just like the fact that as a nurse we're able to really find a solution to anything that they are going through.
What's a typical day for you as a gynaecology and early pregnancy nurse?
So I work on both women's health unit and the gynae assessment unit and early pregnancy unit, which those two are both clinics, and women's health is a ward. So we rotate every week, every month, so we both do clinic work and ward-based work. And so my typical day, it varies really depending on where I'm working. For example, if I'm working on the early pregnancy unit, then it will just be coming in, checking the scan clinic, checking what scans we have today, if any of the ladies need a follow-up. And then because the early pregnancy unit is linked with the gynae assessment unit, I would look at our diary to see if we have anyone coming in for any SMMs, which is surgical management of miscarriage. Basically any miscarriage management, that's what we do in gynae assessment unit. Any cysts, drainage of any cysts, Bartholomew cysts, or any cysts like that, just anything gynae related that a patient could come in and then go out. And we usually do a lot of follow-up with our patients as well. Then on the ward, it's just ward-based care really, just making sure meds are done, discharge planning, just the standard really. So yeah.
Okay, thank you so much, Frances, for coming and being in this video. We've enjoyed hearing your story, and yeah, thank you so much for being here.
Thank you for having me.
Thank you, Frances. So can you just introduce yourself, explain who you are and what you do?
Hi everyone, my name is Ria, known as Re Fitness on social media platforms. I am the founder of Re Fitness PCOS online coaching. So that's online coaching for women with PCOS.
Okay. So Ria, can you explain your chosen topic for this week?
My topic for this week is talking about PCOS, and that is the leading cause of infertility for women. It's a reproductive and inductory disorder. So I was diagnosed quite late with PCOS at the age of 26. However, I was experiencing symptoms from the age of 12, such as irregular periods, weight gain and fatigue. And I got diagnosed with PCOS after a 10-year wait for diagnosis.